Dr. Nuala is a dear friend.
Hello, my name is Nuala Lucas and I work in the UK. I'd like to thank the organisers for laying on this fantastic meeting and asking me to contribute. Over the next 20 minutes, I'm going to discuss some of the lessons learned from the Saving Mothers' Lives report, the UK confidential inquiries into maternal deaths. I don't have any pecuniary conflicts of interest, but I am the anaesthetic co-lead for the inquiries. I'm going to consider the evolution of the inquiries. I'm going to look at some of the lessons we've learned from the inquiries. And lastly, I'm going to touch on the relevance of the inquiries beyond the UK. The first report of the inquiries was published in 1957, covering the years 1952 to 54, and was initially known as the Confidential Inquiry into Maternal Deaths. In 2003, the report was taken over by the group under the name of Confidential Inquiry into Maternal and Child Health, CMATCH inquiries. In 2008, it became the Centre for Maternal and Child Inquiries, CMACE. And more recently, the inquiries have been run by the National Perinatal Epidemiology Unit in Oxford. And the reports are called Mothers and Babies, Reducing Risk Through Audit and Confidential Inquiries, the EMBRACE report. In contrast to early incarnations, when the reports were published every 3 years, reports are now published annually from the inquiries. We look at topics, individual topics such as anaesthesia or hemorrhage, on a rolling cycle every 3 years, rather than examining them in detail every year. We include morbidity as well as mortality data on some topics, and there's a much greater emphasis on learning. So individual EMBRACE reports are now called Saving Mothers' Lives, in contrast to early reports which were known as Why Mothers Die. A really crucial element of the report is the meticulous case ascertainment. So it doesn't just rely on individual hospitals or clinicians reporting maternal deaths to the inquiries, but data that is reported is cross-referenced with data from the Office for National Statistics to make sure that no maternal death is missed. On the left, you can see a figure demonstrating the process that each maternal death goes through in terms of analysis and to try and improve the learning. I don't want you to look in too much detail at it, but I really want to emphasize the very rigorous process of multidisciplinary review. Another element of the report, which I think deserves emphasis, is the use of vignettes, which are anonymized short descriptions of maternal death. And I think the value of vignettes for learning is demonstrated nicely by this comment published in JAMA just over 10 years ago. Facts and figures are essential, but insufficient. Narratives, when compared with reporting statistical evidence alone, can have uniquely persuasive effects in overcoming preconceived beliefs. This figure shows the causes of maternal deaths in the UK. And perhaps reassuringly, you can see that anaesthesia is at the bottom of this list. But I think it's also important to remember that all the other causes of maternal death in this list are disease processes, whereas anaesthesia is, of course, iatrogenic. It's not a disease process as such. And this really behoves anaesthetists to scrutinise the delivery of anaesthetic care to obstetric patients and to make sure we're really optimising and making it as safe as possible to really improve maternal outcomes and reduce mortality related to anaesthesia causes. Let's move on and consider some of the lessons learned from the inquiries. And first of all, clinical lessons. There are some general themes that I want to mention. Wrong or ineffective treatment, poor identification of high-risk cases, poor recognition of non-obstetric conditions, and poor recognition of the severity of illness. And I think this is particularly pertinent with obstetric patients who are generally young and fit and have good physiological reserve, and the recognition of critical illness can often be difficult. Poor use of guidelines, and something that's been very topical in the last few years is poor cardiopulmonary resuscitation of obstetric patients, and in particular the point about proceeding rapidly to perimortem Cesarean section if early attempts at resuscitation are not successful. Looking at some of the specific clinical lessons learned, and I'm going to touch on thromboembolic disease and preeclampsia. This figure shows deaths from preeclampsia in the UK from the 1950s to the current day, looking at cerebral and pulmonary causes. Now, these two arrows demonstrate confidential inquiry reports, coincide with confidential inquiry reports, where recommendations were made about reducing the treatment systolic blood pressure in preeclamptic patients to reduce cerebral morbidity from stroke. And you can see that with the recommendations in this report, i.e. reducing the treatment blood pressure from 180 to 150, that deaths from cerebral causes of preeclampsia were reduced after the publication of these reports. In the mid-90s in the UK, there was a lot of anxiety about deaths in preeclamptic women related to pulmonary edema and fluid overload. The report from 1994 to 1996 advised caution with fluid management and protocolized care. And you can see that pulmonary causes of deaths from preeclampsia after this time very dramatically declined, this yellow line here. Now, if we consider deaths from venous thromboembolism, which we know is a big problem in the obstetric population, following a confidential inquiry report in the mid-90s, the Royal College of Obstetricians and Gynecologists developed very evidence-based guidance for the use of thromboprophylaxis in cesarean section patients. And you can see that deaths from thromboembolism dramatically declined after this point. Following advice from a report in the early 2000s, the RCOG extended this advice to include thromboprophylaxis in all obstetric patients, not just those undergoing cesarean section. And again, you can see the very rapid, dramatic decline in deaths from thromboembolism after this point. Just briefly want to mention some of the lessons for anaesthetists related to the management of obstetric hemorrhage, which continues to be a problem in the UK and beyond. The report has emphasised the role of body weight, recognising that smaller women have lower blood volumes and even relatively low degrees of obstetric hemorrhage can have an impact on these women. The report has emphasised the crucial role of regular monitoring of the effectiveness of resuscitation using point-of-care coagulation and HemoQ assessment. The report has emphasised ensuring that a patient is adequately resuscitated before extubation so that they don't decompensate after extubation. And of course, resuscitation, basic strategies such as adequate IV access, using warmed fluids and blood to maintain coagulation, and rapid infusion devices have a crucial role to play. And lastly, evidence-based management of obstetric hemorrhage using protocols and making sure that these protocols are rapidly available on the labour ward can contribute to improving outcomes in obstetric hemorrhage. A final point that I always think is worth highlighting is this issue about having a senior clinician who can take a helicopter view of the management of a woman with a major obstetric hemorrhage to coordinate all aspects of care. And this can be a senior anaesthetist or a senior midwife, but as long as one person is taking a helicopter view to ensure that no aspect of management is forgotten. Moving on to consider some of the other lessons learned, and of course there's been important organisational lessons learned from the inquiries. We know from the inquiries the value of ensuring that high-risk patients are cared for in dedicated units. High-risk patients shouldn't be cared for in isolated units without appropriate support and backup, or clinicians with experience of managing these cases. We know from the reports of the crucial role of having adequate access to blood banks, intensive care and radiology to provide total holistic care for women who become sick at the time of childbirth. We have also learned from the inquiries the valuable role of chains of communication and responsibility. For high-risk patients, we need to integrate care to make sure that all the relevant people are involved, obstetricians, midwives, physicians and surgeons in some situations. The reports emphasise the valuable role that adequate communication between and within teams. The value of recognising urgency in situations, urgent response to patients who require caesarean section, and urgent response to patients who are becoming unwell, in particular with conditions such as hemorrhage and sepsis. And finally, the report has emphasised the crucial role that senior staff, senior clinicians can have in improving outcomes for obstetric patients who do become sick at the time of childbirth. A final element of organisational aspects that the report has mentioned is this issue of staffing and resources. delayed transfer to theatre or intensive care or to specialised units can have a detrimental impact on obstetric patients. And I think that's something that's very pertinent for anaesthesia is the issue of inadequate recovery facilities, which the report has highlighted on a number of occasions. Regardless of whether they've had spinal, epidural, or general anaesthesia, obstetric patients need the same recovery facility patients as non-obstetric patients to ensure that problems don't ensue in recovery. And if they do occur in recovery, we can respond rapidly to them. So it's essential that obstetric patients have adequate recovery facilities. Other important lessons we've learned from the inquiries has been behavioural lessons. And what I'm really talking about here are human factors, what we've learned about human factors. Human factors describe a wide range of dynamics, including the interfaces between humans, equipment and the workplace, and interactions between team members and individual behaviours. And I think the particular points that are relevant to anaesthetic practice are situational awareness, crisis decision-making, and handovers. So let's talk a bit more about this. So in terms of handovers, in the UK, we try to recommend the use of structured handovers at shift changes. And this is something that's been published in Nigeria and that we use in my hospital. It's safe handover in obstetrics. And SAFE stands for sick patients, at-risk patients, any follow-ups, any patients with post-dural puncture headache, and any epidurals. Who has them? Are they working well? Do any need resiting? I want to say a little bit more about fixation error, because I think this is a critical point for anaesthetic practice. Fixation error describes a situation when a practitioner concentrates solely upon a single aspect of a case to the detriment of other more relevant aspects. And this can lead to delayed diagnosis and a failure to switch a management plan from plan A to plan B when plan A is not working. And the clinical situations where this might be an issue are a failed intubation. So when a failed intubation occurs, it's important that we don't just continue trying to intubate the patient. What we really need to focus on is trying to oxygenate the patient. And similarly, in a patient with a tachycardia, there have been cases described in the inquiries when a tachycardic patient was persistently treated as bleeding when in fact she was suffering from sepsis and vice versa. The last thing I want to consider is the relevance of the UK inquiries beyond the UK. At the heart of the inquiries, it's about improving knowledge. And we know that knowledge is the only instrument of production that is not subject to diminishing returns. So improving our knowledge of the causes of maternal deaths and why care failed is crucial to improving outcomes. Another aspect of the inquiries is that I think they have provided a template for other inquiries to develop their own confidential inquiries into maternal deaths. We've seen this with Malaysia and South Africa and other countries, including France. Many of the lessons that have been highlighted in the reports are applicable to other healthcare settings. And I think that we have much more in common, regardless of the care setting we work in the world, than sometimes we first assume. I think the inquiries have led to the development of national evidence-based guidance with specific recommendations that are pertinent to all healthcare settings. And lastly, I think the UK confidential inquiries really emphasises the value and role of collaborative working in improving outcomes in obstetrics, working with our obstetric and midwifery colleagues, but also when required, working with our surgical and medical colleagues. As I've said, I believe that we have more in common than sometimes we first assume. One of the South African confidential inquiries highlighted a number of deaths related to high spinal block in association with spinal anaesthesia for caesarean section. And similarly, in the UK, the cardiac arrest in pregnancy study also highlighted that there were a number of cardiac arrests related to high spinal block in obstetrics. I would emphasise that all the women who did suffer a cardiac arrest associated with high spinal block in the UK were successfully resuscitated, but it does demonstrate that regardless of care setting, some of our problems are the same. I've already mentioned that the high spinal problem in South Africa, and they've developed this excellent guideline for the management of this problem that I think occurs more widely in the world. It's an excellent guideline that has advice about how to recognise and respond, and I'd urge you to take a look at it. So finally, to summarise, the UK confidential inquiries provide annual reports. We have meticulous case ascertainment to make sure that no case is missed. And there's multidisciplinary confidential review to really maximise the learning. We've learned clinical organisation and human factors lessons from the reports that can help us to improve care for obstetric patients. And lastly, I would emphasise that we have more in common than sometimes we first assume. And I think it's important we remember that whenever we're working and sharing learning together. Thank you for listening.
Thank you so much, Nuala, for that informative lecture. And now we go on to the next speaker, Dr. Manju Sinha, Dr. David Bogod. He's our next speaker. And can I have a CV slide, please?
I think I'm really happy and proud to be presenting Dr. David. He is the ex-president of OA. He's been the former editor-in-chief of Anesthesia, practicing medical legal practitioner, and he practices in Nottingham. Then can we get Dr. Bogod to start?
Can I add something to that introduction?
Yes.
Have you ever seen him dancing? Dr. David is an amazing dancer, and his flexibility, you have to see to believe it. Right, David?
Well, thank you very much indeed for that, Sananda. I don't think my children would agree with you, but thank you anyway. And thank you so much to Sunil and his team for inviting me to Hyderabad, even if I'm enjoying it from the delights that are Nottingham in the autumn. Thank you all very much indeed. I'm going to try to share my screen, if I can find my screen. And if I can't find my screen, I won't share my screen. Where are we? Dum, 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 dum. Hang on just a moment. I can see this is going to be a problem. For some reason, the screen I want to share isn't coming up. Yes. Can you all see that nicely? I hope you can. So I'm going to talk about nerve damage and its impact medico-legally on us and on our patients. I will deviate occasionally away from obstetrics because I think it's quite important to make comparisons where they are necessary to other areas of practice. And perhaps the first thing to talk about, which is a very big topic in the UK, is consent to regional anaesthesia. Or consent generally is a big topic in the UK and has recently been addressed by our General Medical Council. And I think it would be regarded as normal practice in the UK now when consenting somebody to receive regional anaesthesia. We would talk about the most likely risk, after all, which is complete or partial failure to completely prevent pain, but also talk about the risks of nerve damage. You can't discuss what you're going to do to a patient without telling them what the alternatives are, so that's very important too. It's important to make a contemporaneous record of what risks you have discussed with the patient, and the question that should guide you in talking to a patient when discussing anaesthesia or anything else for that matter is, what does this particular patient need to know in order to make an informed decision? And if you want to know more about this, I would recommend you to the Association of Anaesthetists booklet on consent for anaesthesia. And there is a QR code there, which you can flash at if you do it very quickly before I change to the next slide. But you'll find it at the AAGBI website. So I'm going to talk about a number of neurological complications, some of them in obstetrics and some of them not in obstetrics. And here they are. And we'll begin with nerve root damage. And here is a typical case. Now, I have taken cases from my own medico-legal casebook. I've anonymized them and I've altered essentials, which would make them unrecognizable. So they are the vignettes, if you like, of which Nuala spoke earlier. So here's a lady with a BMI of 33, having a combined spinal epidural for elective section. She has a dry tap, first of all, at L4-5, where they can't find CSF, a repeat one space higher, a further dry tap, and she feels severe paresthesia. She gets pain during injection when CSF is finally found, and is left with unilateral L5-S1 damage in the region where she complained about paresthesia when the needle went in. Now, this is pretty typical of nerve root damage from an inserted spinal needle. That's not necessarily negligent. We know nerve damage can occur. We know it's very rare. But when considering whether somebody has crossed the line to negligence, we have to consider whether the patient was appropriately warned, whether when she complained of paresthesia, the anaesthetist responded appropriately by withdrawing the needle and repositioning it, and whether the anaesthetist continued to inject in the presence of paresthesia. All of these things, if there was a failure on the part of the anaesthetist, would suggest that she had been let down by the person with the needle. Let's move from nerve root damage, which is a little bit dull, onto direct trauma to the cord, which is even more rare, but also somewhat more exciting. So this is a photograph that I took in an exhibition called Body Worlds, which was run by a rather mad Dutch professor of anatomy, in which he demonstrates to the general public bodies which have been preserved, cadavers which have been preserved with different dissections, beautiful dissections, I have to say. And this, I think, is the 12th rib. And this is the spinal cord. So let's focus in on what's going on there, because I think this is the region that we think about. So here we are at T12L1, where the cord is supposed to end, and the cauda equina flow out like the tail of a horse. Well, that afterwards what cauda equina means. And I think you would agree with me, and I do accept that this chap's particular preservation technique tends to swell nervous tissue, but it doesn't do what I always thought it did, which is come to a little point, little fine fibers flowing out. So you can see that a needle stuck at or below that level could still meet some fairly meaty bits of nerve fiber and cause damage. So getting below T12L1 isn't the only thing here. You don't necessarily protect yourself from nerve damage. But of course, we don't always get into the space we think we're going to get at. Indeed, studies have just suggested that we routinely don't get into the space we think we're at. So when Ruth Broadbent did this study way back in 2000, she demonstrated very, very effectively indeed by comparing where anaesthetists thought they were with subsequent MRI scans, that not only were we really, really bad at guessing or working out what level we were at, but that we were not randomly bad at it. We always thought we were lower, or we usually thought we were lower than we actually were. So the standard error we make is a one space error, where we're one space higher than we think we are. But you can see that sometimes you make a 2 space, a 3 space, or even a 4 space error. So not only are we not very good at guessing, telling where we are unacceptably optimistic in it as well. This is probably the reason why Felicity Reynolds, in her review of the cases in which she'd reported as a medico-legal practitioner, was able to come up with 7 cases of neurological damage, 3 spinal, 4 CSE, all of them inserted at the L2-3 interspace, apparently, all of whom felt pain on insertion. And only 3 was there free flow of CSF, but in 6, there were subsequent lesions in the conus of the cord. And I think we can see, if I just scroll on to the next slide, my screen's frozen, always good. All right, hang on a moment, we're going to do a little, I've completely frozen here. This is one of the MRI scans, and you can see here, towards the conus of the cord, there is swelling on the longitudinal view, and on the axial view, you can see an actual air-filled cavity within the body of the cord itself, and that is typical of damage caused by a spinal needle hitting the cord. It led me to write an editorial in International Journal of Obstetric Anaesthesia called Keeping in what I called the Reynolds Zone, how to make sure you're in the safe space. And this was the rather catchy, if you like, logo that I came up with. When you palpate the back, if you feel a space when you're palpating at the level of the intercrystal line, go down 1 place. So if you're that space, you go down 1 space from there. If at the level of the intercrystal line you find a spinous process, you go to the spinous process below that, and then one space under that. So feel the space down 1 place, bone poked through, go down 2. I do not have a career as a poet. So that's about avoiding the bottom end of the cord. But what about cord ischemia? And here I deviate from the obstetric arena to a 78-year-old knee replacement patient who had the usual comorbidities of patients in this age group and was on a number of drugs and was, despite that, still at rest hypertensive. And she had a fairly impressive number of drugs to keep her asleep, but she also had a spinal carried out at an unstated level, which was a large dose, a very large dose, some might say, of bupivacaine was administered through the spinal, and she was, and general anaesthesia was induced. And this is her actual anaesthetic chart, and I did receive approval to publish this. And you can see what went on here. So this is the point at which the spinal goes in. Here's induction of general anaesthesia. That is her blood pressure for over an hour in the middle of the procedure. And it is very low indeed. And it's only here that a vasopressor drug is finally given. Just making sure I'm not getting any important messages from you guys while I'm doing all this. No, I think we're okay. So this lady was hypotensive, significantly hypotensive for a very long period of time, and ended up with spinal cord ischemia and complete paraplegia. The common feature of these cases is they are often elderly and frail. They often have a combination of general anaesthesia and regional, which provokes particular significant hypotension. They are sometimes anticoagulated, not infrequently anticoagulated. They're slow to pick up afterwards because they're slow to mobilize because they're elderly, and they have bilateral extensive lesions. And of course, almost impossible to defend a case like that. What about infection and hematoma? Rare, as we know. Thanks to NAP3, the third national audit project of the Royal College of Anaesthetists, published way back in 2009 now, we know that major neurological complications from central neuraxial block are very rare indeed. And indeed, that's confirmed, or was confirmed earlier, if you like, by the big Swedish database study by Lars Irstedt, which showed much the same thing. So in his study, there were 1,700,000 spinals and epidurals. One of the marvelous things about working in Scandinavia is you have access to huge patient databases. And of those, 1 in 13,500 developed major neurological complications, so somewhat larger than the UK incidence, but still low. But when you start to break it down, it gets more interesting. Spinals were very safe indeed. Epidurals were less safe for major neurological damage. Obstetric epidurals, however, were much safer than epidurals in general, probably because of the factors we talked about earlier. But when you get down to particular areas like knee arthroplasty, like my lady, you're talking about 1 in 1,800, which is not uncommon. And again, it's the elderly patient with comorbidities where the problems arise. The reasons are probably obvious. I think they're age-related, the comorbidities, the fact that they can have delicate bones and are more likely to bleed. Concomitant steroid therapy promotes infection, and they're often on anticoagulants as well. It might even be more common than this, actually. Here's a study from 2007, which looked at the incidence of major complications of epidurals following surgeries. This is for post-operative analgesia, a 6-year survey in one centre in the UK on the south coast. And this was remarkable. And what they did was a retrospective case note review of everyone who had a post-operative epidural. If they'd had an MRI or a lumbar puncture within 60 days of surgery, they put that down as a marker of potential hazard, and then got the notes out and looked at them properly. And they looked at a 6-year period of time. Well, they came across 8,100 post-operative epidurals and found 6 abscesses, 3 hematomas, and 3 cases of meningitis. And that's an incidence of 1 in 675. So it may just be that the more you look for these complications, the more you find them. But it's certainly a very sobering business. The key points from this, really, it seems to me, is that major neurological complications are much more common following epidurals for post-operative analgesia than they are for labour, which at least is a good thing for our patients who are in labour. But as I've discovered looking into these cases, back pain and leg weakness are often misdiagnosed. And these cases have occurred in obstetrics as well, where people have been slow to respond to what is clearly an expanding lesion in the neuraxis. And that's important because if you delay decompression, you get a significantly increased risk of a permanent deficit. So medico-legally, if you don't pick it up, you're going to run into trouble. And what about the ones that are completely unconnected or possibly unconnected to the spinal and epidural? This is another photograph from the same exhibition, and we're going back to the pregnant patient here, but here is a female pelvis, and you can see here the lumbar and sacral plexuses, also the nerve roots, running over the internal rim of the pelvis as they exit down into the leg. And you can imagine that a baby's head or a forceps blade pressing against those can cause significant damage, and sure enough, they do. And they're not the only nerves to get damaged during obstetrics, of course, at all. And indeed, we know that obstetric neurological palsy is probably 6 times common, or even more frequently than that, than neurological damage caused by the epidural or spinal needle. But if somebody sticks a needle into the back of a patient who's in labor, and they go on to get neurological damage in the lower half of their body, they are likely to blame it upon the anaesthetist until proven otherwise. And it often isn't down to the anaesthetist. So here is a BMI 32 lady with acute fatty liver in pregnancy, had a cesarean section for failure to progress, tried to get a spinal in, but she complained of paresthesia and they stopped. Gave her a general anaesthetic. She had a stormy post-operative course and ended up with pulmonary edema, a deranged liver function. But when she was all better, she was left with bilateral paresthesia in the lateral aspects of both thighs, which was marked down as being due to the spinal. And it took 3 months to recover. But it wasn't down to the spinal at all. If you looked at nerve conduction studies, which are often the way to deal with these issues if there is doubt, it was actually I've gone frozen again. Actually down to meralgia paresthetica, which is compression of the lateral femoral cutaneous nerve by the edema that she had suffered as a result of her acute fatty liver. So that had compressed the nerve on both sides. As you get a bilateral lesion, it is most unlikely to be down to a nerve root problems due to contact from an epidural or spinal needle. And what about the idiopathic ones? I say idiopathic. Many of you will be familiar with the case of Angelique Sutcliffe, who in 2001 had an elective cesarean section of the spinal, went on to develop very severe neurological problems, leading to obstructive hydrocephalus, an ascending adhesive arachnoiditis, multiple surgeries to promote normal CSF flow and treat a hydrocephalus, and ended up confined to a wheelchair and actually recently died. And this was laid at the door of chlorhexidine contamination, and I felt probably unfairly, because there was no evidence of chlorhexidine contamination at all. But then in 2010, Grace Wang in Sydney did have chlorhexidine injected into her epidural space when the anaesthetist mistook chlorhexidine for saline when trying to find loss of resistance. And she developed a course that was very, very similar to that of Angelique Sutcliffe, suggesting that chlorhexidine causing a severe inflammatory reaction may well have been the cause of both of these incidents, because we know that Grace had chlorhexidine in her neuraxis. This has led to in the UK particularly, us looking at how we achieve skin antisepsis for central neuraxial blockade, and the production of a safety guideline, which I would recommend again to all delegates. And again, there's a QR code if you can snap it up quickly. But otherwise, find it on the AAGBI website. It's about protecting the neuraxius from accidental chlorhexidine contamination. And there are many such cases around the world. So in general, neurological damage looks a bit like this. Complications may be on the rise, actually, but it's important to get the basics right. The post-op elderly community is not the same as the obstetric population and should be treated with great care. Good post-operative care and observation is essential for picking up expanding lesions in the neuraxis. It's very important to consider risks versus benefits and explain them to patients. And there are very rare severe catastrophes. Of my standard slide on how not to get sued, the two most important ones I would highlight for everybody here are the importance of keeping good records and the importance of good communication. And I talk about communication because of this. I've got about 1.5 minutes left, so here it is, 1.5 minutes. Take a look at this video briefly, where I am. Hopefully, take a look at this video briefly. All right, don't look at this video briefly. See if we can run it. No, I don't want to run. Okay, never mind. It's essentially a video of me simulating a difficult spinal. And it led me to try to determine what it was that anaesthetists used as their marker for the number of attempts required. We all write down number of attempts required, don't we, after a spinal or an epidural? And I did a survey nationally, and this was the data that came back to me, and I found it rather disturbing. So this is the proportion of anaesthetists who count the number of attempts by the number of vertebral levels attempted, the number of times the introducer has punctured the skin, the number of times the introducer has been reinserted, whether or not it's repunctured the skin, the number of times the introducer has been reorientated, even if it hasn't come out of the skin at all, the number of times the spinal needle had to be removed from the introducer before it was reinserted, the number of times the spinal needle was separately advanced, and any incidences where the spinal needle was moved backwards before being reorientated. And you can see there's quite a spread. So much so that when I put my simulated video up, I get responses that vary between 2 attempts and 7 attempts, depending upon how people score them. And that makes communication very difficult. It means we're not very good necessarily at communicating with our patients. So if we say if our patients read something in their notes saying, I had 2 attempts and got the needle in, and they felt it more like 7 or 8 attempts, they're not going to believe you and they're not going to trust you. And more importantly, perhaps, it's communication between professionals. Because if you come to see a patient for their second section and you see something saying 2 attempts, that could mean really was just 2 quick attempts, or actually I had multiple punctures made in 2 different intervertebral spaces, which is very difficult to get the message across to the next person coming along. So communication is absolutely key, and I would stress that as my final message. If you want to ask any more questions, do feel free to contact me at my email address. And meanwhile, thank you once again for inviting me.
Thank you so much, Dr. David, for that illuminating lecture. And we'll take the question answers after the session is over. Manju, can you please introduce Dr. Mrinalini?
Yes. The next speaker is Dr. Dr.M.Balki, who is a professor in the Department of Anesthesia, OBGY, as well as Physiology in University of Toronto. She's a consultant anesthetist and a fellowship director in Mount Sinai, has numerous publications and has been invited for many lectures, has been awarded 51 awards, and also has received funding, research funding, by the Canadian Institute of Health Research. I think we're going to get Dr. Mrinalini's talk. Or can we have Dr. Mrinalini's talk, or we'll have to get her live?
Hello, everyone. Greetings from Toronto. I'm glad we could meet on this virtual platform. I would like to take this opportunity to thank Dr. Shilpa Kasodekar for inviting me for this conference. I feel honored and privileged. I have known Shilpa for a long time, since her days of fellowship in OB anesthesia at Mount Sinai Hospital, and we have still kept in touch. Today, I'll be talking about postpartum hemorrhage, and women die from postpartum hemorrhage. Isn't it an irony that one life is lost while bringing another life into this world? Postpartum hemorrhage is one of the leading causes of maternal mortality and morbidity. It occurs in about 5% of vaginal deliveries and 15% of cesarean deliveries. Worldwide, postpartum hemorrhage is responsible for about 25% of maternal deaths, which is equivalent to 1 maternal death every 4 minutes. The morbidity is also quite high, about 20 million per year. In India, PPH is responsible for 20% of maternal deaths. 58% are due to lack of provision for emergency transport at community level. There's a lot that can be done in the initial stages to prevent and treat postpartum hemorrhage. Several etiologies of postpartum hemorrhage have been postulated, and they can be easily remembered by mnemonics 4Ts: tone, tissue, trauma, and thrombin. Uterine atony is one of the leading causes, responsible for 80% cases of postpartum hemorrhage. Recent data suggests that postpartum hemorrhage rates are increasing globally. And particularly, there has been increase in atonic postpartum hemorrhage. So why do we see this increase? It's mainly because of increasing cesarean delivery rates. Even in India, we see that C-section rates have gone up in recent years, particularly in private facility. Also, there have been increases in obesity rates, advanced age, multiple pregnancy because of IVF pregnancies, and rates of oxytocin augmented labor, which all contribute to global increase in PPH trend. There are several risk factors for uterine acne. Some intrinsic factors which prevent the muscle from contracting, such as uterine overdistension seen with polyhydramnios, multiple gestation, macrosomia, morbid obesity, uterine muscle exhaustion, relaxation, such as rapid long labors, high parity, general anesthesia, intraamniotic infections such as chorioamnionitis, prolonged rupture of membranes, and functional anatomical distortion of uterus, and these extrinsic factors such as fibroids, placenta previa, creta, and uterine anomalies. But we have to remember that there could be many patients without any risk factors who could bleed. And on the other hand, there could be patients with risk factors who may not bleed. So it's quite unpredictable. So with regards to the management of postpartum hemorrhage, it comes to initial resuscitation ABC, and then use of uterotonic agents, which will also focus on some conservative surgical methods and radiological techniques. So coming to pharmacological management of postpartum hemorrhage, first-line agents include oxytocin, carbidosin. Second-line agents include ergot, carboprost, misoprostol, and also we have tranexamic acid. So oxytocin is the first-line agent given for labor induction and augmentation to facilitate vaginal delivery. It's also used for prevention and treatment of postpartum hemorrhage. Oxytocin stimulates myometrial oxytocin receptors and increases intracellular calcium and contracts predominantly upper uterine segment. The onset is immediate. It's got a short half-life of 4 to 10 minutes. It's metabolized by enzyme oxytocinase and hence has to be administered in the infusion form, so can be titrated to effect. The side effects of oxytocin are dose dependent, which include hypotension, arrhythmias, myocardial ischemia, water intoxication, pulmonary edema, convulsions, nausea, vomiting, flushing, headache, etc. The physiological effects of oxytocin depend on the number of oxytocin receptors and affinity of oxytocin with the receptors rather than plasma concentrations. The distribution of receptors on uterine surface is quite variable. There are more receptors on the fundus and upper uterine segment than on lower uterine segment. So oftentimes you encounter a situation where fundus has contracted, but lower uterine segment has not. The receptors to oxytocin increase in pregnancy, and at term they are maximum, and at labor there's significant upregulation of these receptors. The myometrial sensitivity to oxytocin is also increased during labor. So if you give small amount of oxytocin, the uterus contracts effectively. But oxytocin infusion during labor downregulates these receptors. So in advanced labor or failed induction, you would see decreased responsiveness, and this phenomena is termed as desensitization phenomena. We validated this phenomena in our lab by conducting some in vitro physiological experiments on strips, myometrial strips obtained from C-section, and we found that oxytocin pretreatment actually attenuates oxytocin-induced contractions in human myometrium. So as you can see here, we pretreated the myometrial strips with increasing concentrations of oxytocin, and then we challenged with additional oxytocin. There was significant reduction in contractility with pre-exposure to high concentration of oxytocin. So this can be reflected in clinical situations in oxytocin augmented labor. Wherein pre-exposure to oxytocin can result in failed labor, resulting in C-section and requiring higher amounts of oxytocin because of unresponsiveness to oxytocin that is administered. So uterus may not contract effectively to oxytocin. Oxytocin during labor is also an independent risk factor for postpartum hemorrhage, and this case control study looked at the dose, duration, and infusion rate of oxytocin at labor in women who had acne versus control group. And they found that all of these were significantly elevated in PPH group compared to control group, almost 2 to 3 times. So how much oxytocin should we use at delivery? These studies, we looked at effective dose 90 of oxytocin to produce adequate uterine tone after cesarean deliveries. We looked at non-laboring women undergoing elective C-sections and laboring women undergoing intrapartum C-sections. And we found that the dose required at elective C-sections is much smaller. It's only 0.4 units, while laboring women require 8 times higher doses of oxytocin for adequate uterine tone. Another study had same findings. Dose infusion rate is again high in laboring women compared to non-laboring women. We also found that morbidly obese women require larger doses of oxytocin. Also, laboring women and high BMI women bleed more compared to elective section women. So this is a high-risk population, and we need to be aggressive with our uterotonic management while dealing with these patients. And we need to remember that these women require bigger doses of uterotonics to get adequate uterine tone at cesarean deliveries. This international consensus statement was published recently on the use of uterotonics during C-section. And these are the first guidelines that differentiate between elective and intrapartum C-sections. The recommendation is to use oxytocin bolus of 1 unit, followed by an infusion. We typically put 20 units in a liter and run at the rate of 125 ml per hour. For intrapartum C-section, the recommendation is 3 units oxytocin to be given slowly because of the risk of hypotension when you give it as a bolus, and then you give an infusion at a slightly higher rate. Coming to Carbidosin. Carbidosin is a synthetic oxytocin analog, which is approved for use in several countries, including India. Now that we have heat-stable formulation, it's quite useful in terms of maintenance and stability. It remains stable for over 3 years at 30 degrees centigrade. When compared to oxytocin, it has got a longer half-life of about 40 minutes, which is 4 to 10 times longer than oxytocin. So we do not need to administer an infusion. It can be just given as a bolus. Because of its similar receptor affinity to oxytocin receptor, it is similarly affected by desensitization phenomena. So how much oxytocin should we be using at cesarean deliveries? Similar to oxytocin, in these studies, we found that at elective C-sections, you require a very small dose of Carbidosin, about 15 micrograms, while in laboring patients, you require larger doses of Carbidosin, about 121 micrograms. But one thing to remember is that laboring women can have side effects in the form of tachycardia and arrhythmias, in addition to hypotension. So we do not recommend going above 100 micrograms because the risk of tachyarrhythmias is much higher as you go above 100 micrograms. We also found that morbidly obese women require a larger dose of Carbidosin compared to non-laboring patients. So again, Carbidosin follows same pattern as oxytocin. So, and we require higher doses in laboring women and morbidly obese women. What do the international consensus guidelines suggest? The recommendation is to use 100 micrograms Carbidosin in elective sections, but you can use as low as 20 micrograms and repeat if necessary. So by using 20 micrograms, which is definitely effective in this patient population, you can use same vial for 5 patients because one vial has 100 micrograms of Carbidosin. For intrapartum C-section, you can use 100 micrograms very slowly. You should not exceed 100 micrograms. So which one of these drugs is superior? This meta-analysis of 30 trials compared Carbidosin versus Oxytocin. They found that Carbidosin was associated with reduced need for additional uterotonics at cesarean deliveries in those at high risk for PPH, and also reduced risk of postpartum blood transfusion. But we need to remember that the studies were quite heterogeneous in this meta-analysis, and there were variations in routes and doses of these drugs. This champion trial compared heat stable 100 microgram Carbidosin intramuscular versus 10 units of Oxytocin intramuscular for vaginal deliveries. This study was conducted in 10 countries, 23 centers, and they found that Carbidosin was non-inferior to Oxytocin for several outcomes, including blood loss, additional uterotonics, and adverse effects. So this implies that Carbidosin is equally effective or superior to Oxytocin. Coming to second-line uterotonic agents, which include ergot, carboprost, and misoprostol. Ergot exerts its uterotonic effect by stimulation of alpha-adrenergic and serotonin receptors on myometrium. It also causes vascular constriction and cessation of bleeding. Rapid IV bolus is not recommended because of the risk of hypertension. It also causes coronary artery spasm, intracranial hemorrhage, nausea, and vomiting. It is relatively contraindicated in preeclamptic patients. It can be given intramuscularly or slow IV or orally. Carboprost is a 15-methyl-PGF2-alpha, which is actually relatively contraindicated in patients with reactive airway because the risk of bronchospasm in these patients. Other side effects include nausea, vomiting, diarrhea, pulmonary hypertension, pyrexia, hypertension, flushing, and headache. There's no IV preparation for this drug. It can be given either intramuscularly or in the myometrium. Misoprostol is a synthetic PGE1 analog which binds with prostaglandin receptors. It comes as tablets, so no cold chain maintenance required. It can be administered orally, sublingually, rectally, or vaginally. Sublingual route has the best bioavailability, but rectal route is tolerated better. The side effects include pyrexia, shivering, nausea, vomiting, and diarrhea. So which second-line uterotonic is a better uterotonic? Currently, there are no studies comparing these drugs, but this Maternal Fetal Medicine Units Network Cesarean Registry from United States compared ergot versus carboprost for hemorrhage-related morbidity, which included blood transfusion and surgical interventions in these patients. And they found that the morbidity was higher with carboprost than methyl ergonovine, suggesting that ergot is a superior drug compared to carboprost. International consensus statement suggests ergot 200 to 500 micrograms IM or slow IV, which can be repeated every 2 hours. They also recommend the use of misoprostol in tablet forms, sublingual, rectal, vaginal, oral, can be repeated every 15 minutes, maximum of 800 micrograms. Carboprost can be given IM or intramyometrium every 15 minutes, up to 8 doses. And there's an additional drug, sulprostone, which is again not available in Canada. We recommend this rule of threes in the event of postpartum hemorrhage, which includes oxytocin in the dose of 3 units bolus over 30 seconds, wait for 3 minutes. If the tone is inadequate, give additional 3 units of oxytocin bolus, and you have option for using one of the 3 additional uterotonic agents, ergot, carboprost, or misoprostol. You can continue to monitor these patients every 3 minutes and give 3-unit boluses of oxytocin. If the tone is adequate, you continue with oxytocin maintenance infusion. And we find that this can be easily remembered and implemented in clinical practice in the event of postpartum hemorrhage. Coming to tranexamic acid, this woman trial was published in 2017, was conducted in 193 hospitals, 21 countries, and included 20,000 women with clinically diagnosed postpartum hemorrhage. And they looked at the effect of early administration of tranexamic acid 1 gram IV on mortality, hysterectomy, and other morbidities. Although their primary composite outcome of death from all causes or hysterectomy was not different between tranexamic acid and placebo group, they found significant reduction in the incidence of death due to bleeding, particularly if given within 3 hours of bleeding, and laparotomy for bleeding. These were significantly less in tranexamic group compared to placebo group. Interestingly, adverse effects, including thromboembolic effects, did not differ between tranexamic acid and placebo group, despite pregnancy being a procoagulant stage. So this gives an reassurance that tranexamic acid is safe to use in pregnant population. Following this study, WHO recommended the use of tranexamic acid for the treatment of postpartum hemorrhage. They recommend early use of tranexamic acid, possibly within 3 hours of delivery, in addition to standard care in patients with clinically diagnosed PPH, regardless of the mode of delivery. It should not be initiated for more than 3 hours after delivery. It should be used in all cases of PPH, regardless of cause, and should be given as a fixed dose of 1 gram slowly over 10 minutes. And second dose can be given if bleeding continues after 30 minutes. So coming to conservative surgical and radiological methods, these include Bakri balloon catheter, which can be inserted in the uterine cavity. It's like a Foley catheter, and it allows the drainage of blood through this catheter. Can be kept in place for about 12 to 24 hours. The success rate is 86%. Another method is V-Lynch compressive sutures, which are the sutures can be applied across the uterus, and these have tamponade effect, and thereby they stop bleeding. The success rate is about 95%. And then lastly, if the patient is stable enough to go to radiology, then embolization of uterine and internal iliac arteries can be performed. And these would identify bleeding vessels. And if they are embolized, bleeding will stop. So again, the patient needs to be stable in order to go to radiology. The success rate is reported to be 87 to 95%. So just to wrap up, we know that oxytocin and carbidosin are the most effective uterotonics as sole agents. Carbidosin may be superior to oxytocin. Oxytocin receptor desensitization reduces the efficacy of oxytocin and carbidosin, so you have to give bigger doses in women with augmented labor. And also we have to consider dosing based on other specific patient-related factors such as high BMI and other comorbidities. All uterotonics have dose-dependent side effects, so we need to use minimum effective doses. And second-line agent should be considered early. Ergot may be superior to carboprost, and we should consider surgical, conservative, and radiological methods in order to avoid hysterectomy. Thank you very much. I'll be happy to take any questions in the live question-answer session.
Thank you, Mrinalini. That was a very informative lecture. And thank you for joining us from Toronto. So now the house is open for question answer session. Hi, Nuala, it's great to see you. So how is the COVID situation in your place?
Yeah, it's not too bad. I've slightly lost track of which wave we're on. There's definitely a bit more COVID around, but we're not being overwhelmed at the moment, and we've started our booster vaccinations, which is quite nice. How is it with you guys?
Well, in some pockets of India, the incidence is much higher, like the south of India. But in my state, Udaipur, the incidence is pretty low. So, Nuala, I wanted to ask you, has COVID these 2 years affected your recording of CMAC or Embrace?
Yeah, good question. So we've actually produced, in terms of affected our ability to record and to analyse, no, it hasn't. I think there's such a well laid down and rigorous system. We've still picked up all the maternal deaths and we'll be analysing them in the same way. What we have done, and it's probably a discussion for another time, but we've produced a couple of rapid reports looking at maternal outcomes from COVID. So we produced one, both of them came out towards the end of last year, and there's quite a lot of useful information about not just how COVID had a clinical impact. I think initially we all felt that COVID wasn't too bad for pregnant women. Outcomes didn't seem to be any worse than the non-obstetric population. But now I think we have fairly good evidence that the chances of getting onto an ITU if you're pregnant with COVID are fairly high. So there's the clinical element to it, but there's also the organisational element to it, just simply the fact that hospital services and care was totally diverted towards caring for COVID patients. And that's had an impact in other ways, with people presenting perhaps later with other pathologies, including pregnant women presenting later with other pathologies than they may have done in a non-COVID era. What else was it? The other interesting element to it was ECMO, the use of ECMO. I don't know about in India, but certainly ECMO proved to be very useful in the UK as a strategy in some patients. And we found that pregnant women perhaps weren't as referred as promptly as they may have been. I think people were reticent to refer pregnant women for ECMO, so that was a useful finding as well. So several interesting things, and if anyone's interested, they can email me and I can send them the links for the rapid Embrace COVID reports.
Okay. So what about the maternal incidence of maternal complications? Have they increased in terms of maybe cardiac disease or diabetes or preeclampsia? Have they increased in the post-COVID era? It's not yet post-COVID, in the COVID era, I should say.
I think there's definitely an association between COVID and preeclampsia, and we're still trying to get a bit more granularity on that association, whether it's an association or whether it does seem to be something about COVID that makes you more vulnerable to developing preeclampsia. Or we know that if you've got preeclampsia and you get COVID, the outcomes are worse. So I think it's a bit too early to say for certain, but I think that's going to be something that emerges over the next 12 months. And of course, the big question we're all asking ourselves is, what will be the impact of long COVID on the obstetric population? I think, we're dealing with one acute problem, but the acute problem is going to become a chronic problem, and the impact of that on the obstetric population and on the perioperative population in general is going to be a big question for the medium to long term.
Yeah, thank you so much. And we hope in the near future we'll be able to set up our own national registry and try to, generate some results there, because that is where we are lacking. And another thing you said was a helicopter view in a bleeding parturient. Truly a very, very effective way, but with the reduced number of anesthesiologists we have, we really are at a loss how to provide that helicopter view.
I agree. It's, in a true catastrophic hemorrhage, everyone is busy doing something, but it doesn't necessarily need to be an anaesthetist, just anyone who's sensible, any clinician, a midwife, a nurse, an obstetrician, somebody who can just stand back and say, have you done this? Have you done that? Because I think we all get very task focused in those sorts of situations. We're all about getting the access we need, about giving the blood and the products. But, on occasions, I find myself, gosh, the tranexamic acid, have I given that? It's such a core component, as Dr.Balki mentioned. But, even the most experienced of us can forget some details sometimes. So, I think if just a sensible person, a sensible clinician.
Like you said, we all go into that fixation error.
Yeah.
Yesterday, Sunil talked about it. Like for post-dural puncture headache, you keep thinking it's PDPH, and it turns out to be a space-occupying lesion.
Absolutely. And we've all done that. Thank you, Sanaj. I just want to say thank you for asking me to speak, and it's so great to see my colleagues in India, and we watched the news with horror when you were going through really difficult waves, and it's so good to see that you're all so well and you're all coming out of it. So sending love to all colleagues and friends in India.
Oh, thank you so much, Nuala. Sunil and Manju.
There's one more question for Dr. Bogod, if you can just read out that in the chat box.
Yes, Dr. Bogod, there's a question for you.
A patient with incidental prolapse with herniation of sac at L4, L5, S1, would it be a contraindication for a neuraxial block?
I'm sorry, did you say she had a prolapse?
Prolapse disc with the...
Prolapse disc. Well, yes. And my immediate answer would be no. A prolapse disc should not in any way impact upon either the efficacy of spinal or epidural, and more importantly, spinal and epidural are not going to impact upon the pathogenesis of a prolapse disc. The problem, as ever, here lies with the patient's perception and the perception of those advising her. So if she's got a prolapse disc in pregnancy already, she may be getting neurological signs. The natural progression of a prolapse in pregnancy is that the symptoms will get worse, and indeed in the peripartum and postpartum periods. And if in the middle of all that you stick a needle in the back as well, then they're going to try very hard to blame that deterioration upon the poor person with the needle. The fact is, patients like this just need to be counselled very carefully indeed. But if they want a neuraxial block, it can be very helpful indeed. As you know, the pain of prolapse exacerbates the pain of labour quite dramatically, and it can be very difficult for a woman with a pre-existing back or a neurological condition in her lower limbs to cope with labour, and an epidural can really help.
Yeah.
Mrinalini, there was a question for you. So I wanted to know, in pre-eclamptic parturients, what is your experience with Carbidosin? Is it any different from Oxytocin?
That's a good question. It's actually Carbidosin and Oxytocin work very much similar, in a very much similar manner. So I would say like the incidence of hypotension, tachycardia, whatever you see is very, like they go parallel to each other. So that's not a problem. We haven't used so much of Carbidosin like in specific population. We haven't studied that in a particular population. But I would say like based on, I believe in UK, they're using more Carbidosin than we are using here. We are currently using for research purposes only, which is mainly because of the cost associated with it. But in my opinion, it would be exactly similar. The only thing we notice is hypotension is more. Regardless of what dose you use, we see more hypotension with Carbidosin. So as long as you are aggressive with, but preeclampsia, that shouldn't be a problem because blood pressure is high. Yeah. On the other hand, if the patient is bleeding, then blood pressure might be low as well. So again, like you have to titrate blood pressure, and you have to try to make sure the blood pressure is okay when you're giving this drug. That's the only thing. But other than that, I would say it works very much similar to Oxytocin.
Do you have any experience, Nuala, there with Carbidosin?
That's really interesting. So we don't use Carbidosin in my hospital. We've applied a couple of times to our Drug and Therapeutic Committee, and they've so far declined because of the cost. But one of our neighbouring hospitals has got a lot of experience with it. And I think the really key element to it is that it's not just simply about the comparing the Carbidosin one ampule with Syntocinon on 1 ampule. I think the way that we've tried to frame our application to the Drug and Therapeutics Committee is to take a broader look at the whole impact. So, for example, we use a lot of Syntocinon infusions in my hospital, which keeps patients in recovery for a longer period. So, and of course, if you give Carbidosin, you don't need to use an infusion. You can potentially get them back onto the postnatal wards more rapidly. So it can assist with programs like enhanced recovery in obstetrics. And of course, when you're using Syntocinon infusions, they have their own cost. And there's also the potential for drug errors that you need to take into account as well with, infusions for long periods. So I think a simple comparison of the cost of the drugs doesn't really help with trying to assess the suitability of either drug. And I think you have to take a much more nuanced look at it. I think the thing that's holding Carbidosin back at the moment is that although there's been several systematic reviews based on, fairly good trials, there's no truly compelling evidence at the moment that states that it is a better drug. And I think that's what's really holding it back and preventing its use, its broad stream use in countries that can afford to pay for it. So I think until we get that truly compelling evidence, because it's actually not that expensive really, but until we get that truly compelling evidence, I suspect it won't enter mainstream use just yet. But that's just my view. I mean, I don't know what Dr. Balki or David thinks.
Actually, here in some of the provinces, they are routinely using Carbidosin. Even our Canadian guidelines have implemented Carbidosin as first-line drug as opposed to Oxytocin. So change is coming, but again, we don't, like as you said, we don't have a strong evidence and cost, like if you continue infusion of Oxytocin. And again, we don't know how long we should run Oxytocin infusion for. Like some places run for 2 hours, some 4 hours, some run for 8 hours. So we don't know we are doing one study right now looking at how long we should be running this infusion for. But again, there are like so many things that we still don't know about these drugs. But Oxytocin has been proven, it's been used for so many years, so we're still comfortable using Oxytocin. We have infusion pumps now, so we run Oxytocin through, like after we give the initial, like you want the uterus to contract initially and then maintain that contractility. So we give this initial small bolus of either 1 unit or 3 units, and then run an infusion about 125 ml per hour, which we continue here for 8 hours. But again, we question ourselves, do we really need to run it for such a long time?
Another question, Mrinalini.
Yes.
Supposing you have given Carbidosin in a patient with preeclampsia. Now the duration of effect is 40 minutes and you find the patient is bleeding, you need a second uterotonic and you switch over to Oxytocin. Is that an intelligent decision? Would you reduce the doses? What would you do in this situation?
No, that's a good question. Depends on what initial dose of Carbidosin you have given initially. If you have given, like I won't go above 100 micrograms dose of Carbidosin. That's the thing. And a lot of people have asked me about this question. Would you run Oxytocin infusion? Would you give additional Carbidosin? And that still we don't know. But I think it just makes sense to just move on to a different uterotonic agent at this time, either Hemabate, misoprostol, and even Ergot. It's relatively contraindicated. If the blood pressure is reasonable and you need to give a small dose, you can give it IV really slowly. You can give half the dose of Ergot, and that should be acceptable as well. But I won't keep on giving the same drug because we know it's got side effects by itself.
Thank you so much. Are there any other questions, Sunil or Kajal?
No questions.
Okay, so we wind up this session. And thank you so much, David, Nuala, and Mrinalini, for that interesting session. Thank you. Thank you so much.
Thank you for having us.
Thank you for having us. Great to see you.
Thank you, speakers of
Thank you
session.
very much, everybody.
Yeah. Thank you, Dr. Sunanda, Madam, and Dr. Manju Sinha for moderating the session 1. I request Sunanda to stay back because she has a talk in the session 2. May I request my co-moderator, Dr. Angelina, also to come in now?
Yes.
Dr. Angelina, are you here?
Yes,
Yeah.
I'm there.
So may I request you to introduce Dr. Anjandrika, the first speaker, and then we'll start the session.